This is the lecture over Parkinson's disease, chapter 36. So what is happening in the body? With Parkinson's disease, it's a progressive deliberating movement disorder. It's caused by overstimulation of the brain by acetylcholine. Overstimulation of acetylcholine occurs because dopamine production is decreased in the brain. Dopamine is a neurotransmitter that inhibits the function of acetylcholine-producing neurons, allowing for control over voluntary movement. Therefore, when dopamine is deficit, acetylcholine, which is excitatory, will dominate and make smooth, controlled movement difficult. So for your assessment findings, these key features are found in box 36.6 on page 894 in your book. Stage 1 is the initial stage. In stage 1, you'll have unilateral limb involvement, minimal weakness, and hand and arm trembling. In stage 2, this is a mild stage, and it will indicate bilateral limb involvement, a mask-like face, which is pictured below, and slow shuffling gait. In stage 3, this is the moderate disease. There'll be postural instability and increased gait disturbances. And then stage 4, the severe disability. There'll be akinesia and rigidity. Stage 5 is complete ADL dependence. Characteristic symptoms of Parkinson's disease do include tremor, muscle rigidity, bradykinesia or akinesia, so slow movement or no movement, and postural instability. Parkinson's disease interferes with movement due to the loss of dopamine in the brain. PD reduces the sympathetic nervous system influence on the heart, blood vessels, and other areas of the body, so orthostatic hypotension, drooling, nocturia, and excessive sweating are also signs. It is also associated with the loss of the nerve endings that produce the chemical messenger norepinephrine, which controls the sympathetic nervous system and is responsible for the regulation of heart rate and blood pressure. Labs and tests. Diagnosis is made based on clinical findings and other neurologic diseases being eliminated. So there's no specific test for diagnosis. Abnormal structures formed inside the nerve cells in the brain, referred to as Lewy bodies, are a hallmark finding associated with Parkinson's disease. However, their contribution in the death of neurons is unknown. Analysis of cerebral spinal fluid may show a decrease in dopamine levels. Some diagnostic tests may be done, such as single photon emission computed tomography or SPECT, to rule out other CNS health problems, and SPECT can also reveal a loss of dopamine-producing neurons. A newer imaging test called a dopamine transporter scan, or DAT, may be performed via SPECT to confirm abnormalities in dopamine transmission in the basal ganglia. This scan uses a radioactive agent that binds to DAT proteins in the substantia nigra and is used to monitor neuronal degeneration. More information about SPECT can be found in chapter 35 of your book. So nursing interventions and treatments. Decreased mobility due to muscle rigidity, resting tremors, postural gait changes. Our desired outcome is to maintain mobility and decrease ADLs as long as possible. This can be achieved through non-pharmacologic and pharmacologic interventions. So some non-pharmacologic interventions refer to box 36.7 in your book, Care a Patient with Parkinson's disease. So things like allowing for extra time for them to respond to questions, administer medications promptly, provide any drug therapy for any pain or tingling in their limbs, monitor for side effects of medications, such as orthostatic hypotension, hallucinations, and acute confusional state, which is delirium. Place them on fall precautions. Consult PT and OT. Allow the patient to perform ADLs and just assist as needed. Prevent complications from impaired mobility, such as constipation, pressure injuries, and contractures. You want to schedule their appointments or activities late in the morning or when it's the patient's optimal time of functioning. Teach the patient to speak slowly and clearly, or use any alternate communication. Monitor their ability to eat and swallow and monitor their intake. Collaborate with a dietitian or nutritionist, and then focus on the patient's strengths. Assess the patient for any depression, anxiety, or impaired cognition, and for any insomnia or sleepiness. Other interventions: if they have a freezing gait, you can attempt 2 different maneuvers or 3 different maneuvers. Have them try to step sideways before they step forward, or they can shift their weight from side to side before they step, or they can imagine an object on the ground and try to step over it. Early in the disease, yoga or Tai Chi may be beneficial also. Active and passive range of motion exercises, muscle stretching, and out-of-the-bed activities. You can collaborate these out-of-bed activities with PT and OT. They may have impaired sleep because of drug therapy and the disease itself, and you want to assess, can they function and operate machinery or vehicles safely? They may be able to early in the disease, but as the disease progresses, you would want to evaluate their ability. Small, frequent meals may be required, and thickened liquids as well if they have trouble swallowing. This is to help make it easier for them to swallow and for them to prevent any aspiration. Reduce their environmental noise to increase the listener's ability to hear and understand. Ask the patient to repeat words that the listener does not understand, and have the listener watch the patient's lips for nonverbal expressions. And remind the patient to organize thoughts before speaking and use facial expressions and gestures if possible to assist with the communication. Some pharmacological treatments that can be provided. Pharmacological can take several weeks before you know any improvement. Maintenance of therapeutic levels is necessary for adequate control. So one is dopamine agonist. So pramixol or ropinirole. It mimics dopamine by stimulating dopamine receptors in the brain. It may be used with dopaminergic, and you want to monitor for drowsiness, orthostatic hypotension, dyskinesia, and hallucinations. Dopaminergic, such as levodopa, carbidopa, is immediate release and controlled release. Levodopa are converted to dopamine in the brain, and it may be combined with carbidopa to decrease peripheral metabolism of levodopa. That requires a smaller dose to make the same amount available to the brain. Due to medication tolerance and metabolism, medication dosage, route, and timing may be adjusted to treat immobility. You want to monitor for wearing off phenomenon and dyskinesia, which can be an indication that the medication needs to be changed or the patient may need to take a drug holiday. Long-term use of levodopa preparations can lead to dyskinesia, which is the inability to perform voluntary movements. Long-term use of levodopa preparations can cause the same effects as dopamine agonists. COMT inhibitors or compounds are entacapone, opicapone, tolcapone are enzymes that inactivate dopamine. They can help prevent wearing off effect of levodopa. COMT inhibitors block the enzyme activity, prolonging the action of levodopa. You would want to monitor for dyskinesia when used with levodopa and assess for diarrhea. Dark urine is a normal finding. MAOIs, silgiline and rasalgiline, help decrease dopamine concentrations and protect neurons in the brain. Reduce the wearing off phenomenon when administered with levodopa. You want to avoid alcohol and foods containing tyramine. Tyramine can cause hypertensive crisis. Anticholinergic benztropine may be prescribed for severe motor symptoms and tremors in younger Parkinson's disease clients. It's rarely used as primary drugs or in older adults due to the adverse side effects of acute confusion urinary retention, constipation, dry mouth, and blurred vision. For any long-term Parkinson's disease medication, drug tolerance and toxicity can develop, and the drug benefit decreases with time. Toxicity evidence evidence of toxicity include delirium and hallucinations, and you want to treat for toxicity by reducing the dose or frequency or having a drug holiday, usually lasting 10 days with no Parkinson's disease medications. So risk factors include the onset between 40 years old and 70 years old. It is more common in males and those with a genetic predisposition. Also, patients with traumatic brain injury have a higher incidence of Parkinson's disease. Exposure to environmental and chemical solvents, such as veterans who are exposed to Agent Orange and other herbicides and chemicals during the Vietnam War and other military deployments, are also risk factors. Complications include aspiration pneumonia, altered cognition, UTI and skin breakdown, and depression. With aspiration pneumonia, it's that alterations in chewing and swallowing that increases this risk. So you want to use swallowing precautions. Have a diet plan based on speech recommendations. Supervision when they're eating. They should be encouraged to eat slowly and chew thoroughly, and feed in an upright position, and have suction available in case they start to cough or choke. With the altered cognition, you want to provide a safe environment. Develop comprehensive plan with family, client, and interprofessional team to keep them safe. For urinary incontinence, you want to monitor for that, and for urinary retention, and then monitor for skin breakdown and provide skin care, which includes turning client frequently. For depression, you want to monitor for signs and symptoms of depression and encourage the client to set realistic and achievable goals. Patient teaching for management and prevention. This can take several weeks of use before improvement and manifestations is seen. You want to monitor for any adverse effects of medications and when a drug holiday may be indicated. While the client is taking a combination of medications, maintenance of therapeutic medication levels is necessary for adequate control, and long-term treatment care must be accommodated. As the disease progresses, client will need referrals to and support from speech therapy, occupational therapy, physical therapy, and social services. The end.